Okay. All right. Okay, good morning. I have the opportunity this morning and the pleasure to welcome Dr. Ken McDonald, who is the Medical Director and Vice President of Government Services for the U.S. branch of International SOS. Dr. McDonald will chair this morning's panel on the Zika response. Ladies and gentlemen, Dr. McDonald.
Yeah, thank you very much, John, and I'm glad so many of you got up for this Reveille session. I kind of feel like I'm in my living room with these comfortable chairs, and luckily I have the remote, so we'll go to the next slide. For those of you who are here, we're going to be talking about Zika and mainly private and public interaction in this epidemic. This is the obligatory administrative slide. We have no financial disclosures, none of the speakers on this stage. And just to go over some of the main objectives of this presentation, we know that Zika has dominated the news cycle over the last 10 to 12 months. It's still in the news with the case that we just saw 2 days ago, the first case in Texas, in Brownsville, where a woman was infected with the native Texan mosquito. And we're going to take a look in the context of the Zika virus to examine two main themes. One of is duty of care. What role do the governments have, do the Defense Department has, corporations have in protecting their expats and the workers that they send overseas to mitigate against the health and security risks that may exist and to inform them of these things and then to take action. The other thing is to take a look at the way that the public and private sectors actually are cooperating. We'll take a little bit of a look at Ebola and then focus on the Zika virus and maybe come up with a good way ahead to further strengthen academia, private sector, and whole of government when we face the next epidemic. You can get CME for this activity at the following website. And without further ado, let me introduce the panelists here. To my right, I have Dr. George Narby, the Global Medical Director for the TRICARE Overseas Program for International SOS. Then I have Colonel Rudy Cachuela. He's the Command Surgeon for United States Southern Command, and many of his troops were really in the bullseye of this epidemic as it burgeoned over the last year. There's Marcelo Targino from Johnson & Johnson Global Health Services. And then we have Dr. Ripley Ballou from GlaxoSmithKline, the Global Vaccine Center. So this will kind of be like a presidential debate format. So I will be the moderator playing kind of the Anderson Cooper Lester Holt role, and I'll be providing a little brief overview of Zika, and then I'm going to fire questions at these panelists. We hope to leave plenty of time because we know that all the expertise does not reside on this stage. So there are microphones here, and there will be one being passed around at the end of the session so that you can provide comments and further insight to all of us. Okay, last year we sat on this stage and we talked about Ebola virus and all the great activities that were being done in Sierra Leone and Liberia and Guinea. And I think we came to the conclusion that we need to have better private-public sector collaboration. I mean, it's really not a new topic. In January 2015, in kind of a post-mortem of the Ebola virus at the World Economic Forum in Davos, Switzerland, all parties agreed on the need for a large unified body capable of reacting to any initial sign that an epidemic may break out. And the private sector was best to incorporate in the early stages. History kind of played itself out in the same way in the Zika epidemic. When we look into July 2016, the Department of State sponsored kind of a multimodal conference involving academia, private industry, and most of the government services. And they kind of echoed that same role, that the Department of State assumed the role of a convener, building a team of people, and public-private partnerships, which have proven essential to the whole of society response in malaria in sub-Saharan Africa, needs to be strengthened in this current Zika response, and the partnerships have to be done right. And today we're going to look at some of the things that maybe we can do to make these partnerships right. Okay, I'm going to give you the fastest overview of Zika, and then we'll get right to the panelists. So Zika virus is not new. It's been around for about 70 years, named after a forest in Uganda. Before 2007, very few cases actually noted. Of note, several outbreaks before the latest one in Brazil in 2015. Probably the best studied was in the French Polynesia and Tahiti and New Caledonia back in 2013 and 14. And by the fall of 2015, with some careful analysis by Didier Musso and other investigators, it was actually causally linked to cause central nervous system difficulties, to include microcephaly and Guillain-Barré syndrome. The difficulty, of course, with Zika is that because of the background of dengue and chikungunya in the same locations, it was very difficult to actually be certain that Zika was the cause of some of these previous diseases. Let's fast forward to the current outbreak. May of 2015, the Pan American Health Organization issued an alert with the first confirmed Zika case in Brazil. The CDC subsequently took action, and the first travel notice was issued in June. October, November, December, January of 2015, 2016, there were over 3,500 reports in case clusters and sporadic reports of microcephaly in Brazil. The CDC stepped up its efforts and activated its Emergency Operations Center in late January of 2016. And this is very significant. The WHO actually declared a public health emergency of international concern on the 1st of February. Now remember, they've only done that 3 times in the past. One was H1N1 in 2009. One was a polio epidemic in 2014. And then one was the Ebola outbreak in August of 2014. Of note, the WHO did not declare the Ebola public health emergency until about 5 months into the epidemic. And at that time, nearly 1,000 people had died. They declared this public health concern after only 3 deaths, but with all the case clusters and the several thousand reported cases of microcephaly, the WHO decided to take action. Ultimately, the CDC upped its level of activation in its Emergency Ops Center, and it remains at that level to date. After the declaration, funding requests immediately occurred, with President Obama asking for $1.8 billion in emergency funds. And this is important. In March, the WHO kind of strengthened its recommendations in terms of travel, saying that pregnant women should be advised not to travel to ongoing areas of Zika outbreak. Subsequently, there was funding granted in September in a supplemental and a continuing resolution. And somewhat controversially, just about 12 days ago, the WHO actually ended the public health emergency of international concern, citing the fact that this is going to be an ongoing threat and it's going to require a constant response. As we know, currently, outbreaks have occurred in more than 60 countries across a wide swath of Latin America and Asia. This is where we stand kind of in the US, and I won't go over the numbers, but almost 40,000 cases. Puerto Rico has been hit extremely hard with over 30,000 cases reported as of November of this year. When you look at pregnancy, by the way, most of the cases that you can see were from mosquito. In terms of sexual transmission, only about 36 cases reported. Pregnant women, over 1,000 in the US. Looks like the incidence of birth defects of any kind are just over 2% as of November this year. What makes Zika kind of scary is the multimodal transmission that it can actually be passed on by. We all know about Aedes aegypti and albopictus as being the primary vector of this disease, but it can be passed vertically, obviously, from an infected pregnant mother down to the infant. Sexual contact, a little bit scary in that neither partner actually has to be symptomatic at the time of transmission. Still a lot of work to be done in terms of how long the virus may last in genital fluids, whether the disease is different when it's passed sexually versus via native mosquito. But it did lead to a host of recommendations related to what happens after you come back from travel, with the idea that it may persist longer in semen. So women would have about 8 weeks of abstinence or condom use after travel, and men, the recommendation is still about 6 months. The blood supply, when we looked at the French Polynesia outbreak, about 2.8% of the donors were positive. And as we'll see later, it created quite a lot of problems in Puerto Rico in March and April this year. As we know, I think as the case reports came in October, November, December, there was quite a scare, and so ultimately the science did prove that the virus was isolated in fetal tissues and that it is the cause of the microcephaly. Of note, Guillain-Barré syndrome in the adults is also associated with this, and it was in the French Polynesia epidemic as well in 2013 and 14. One of the two main themes that we talked about was kind of duty of care and what responsibilities we have corporately and governmentally to be able to mitigate against travel risks to our beneficiaries. The CDC had posted this notice since January, and it's a level 2 warning in terms of practicing enhanced precautions that you should seek advice of your doctor prior to traveling. As I mentioned, in March, the WHO actually kind of strengthened that warning, advising pregnant women not to travel to Zika endemic areas. The CDC has taken quite a lot of actions. I think if you come to the Reveille session tomorrow, you'll hear the Public Health Service response, but they jumped in with state and local officials on the 1st of April to come up with the Zika action plan, which had quite a lot of risk communication and looked at some of the issues that were going on with lab testing, surveillance, and vector control at the time. Okay, so how did we look to solve this? Well, one of the interesting solutions was to use genetically modified mosquitoes. Those that, when they bred with the native population, would actually result in their death. Oxitec has been around for a number of years. It has had clinical trials in Grand Cayman Island as well as in Brazil, in which it showed some efficacy in reducing the native mosquito population by up to 80%. And of note, the FDA has pledged in this epidemic to actually cooperate very well with the private sector. And this is one example where the Oxitec actually applied for an environmental impact assessment in March of this year. And ironically, just after the first cases were reported in July in Florida, the FDA completed its environmental review, and it was findings of non-significant impact, which allowed then this Oxitec and this genetically modified mosquito to proceed. It hasn't to date, but the FDA was cooperating very closely with private industry in trying to come up with a solution to this issue. We saw quite a bit of different rapid Zika kits, prevention kits, and I'm going to start the questions now because I think I've talked long enough. And the first one is for Dr. Targino. There have been a number of products now commercialized for help in the prevention of Zika. Can you tell us how you mitigate against the risk of Zika among your workforce? I know you have an incredibly diverse population with both local nationals and then expatriates working in a large number of countries.
Hi, morning, folks. So there were two main strategies that we used. We did put out an early communication in 1st of January to all our population worldwide. And we did not endorse one particular brand name of a product, but we listed the types of products and also mechanical devices such as a mosquito net if locally applicable. We also, for European and American folks who are traveling for business, we have a travel medicine program where we give out travel kits, and they have some acetaminophen, some Band-Aids, things that you would need in emergency, and we started including mosquito repellent as part of that travel kit. So I think the majority of our effort was on education and providing a list of supplies that you could acquire locally, but we also made an effort for a specific outreach to travelers in particular to make that more convenient for them.
Great, thank you. Now, we know also that there were Zika prevention kits that were being kind of packaged up. The CDC Foundation actually collected money to be able to send it to Puerto Rico. And Colonel Casuela, I know it kind of being in the epicenter of this epidemic with your folks, with all the assortments of products, can you tell us how you protected or gave education to the men and women in Southcom?
Yeah, thanks, Ken. Sure. For years, it's always been a focus from a forest health and protection standpoint from Southcom to prevent vector-borne diseases. And so we've always had in our reporting instructions pre-treating uniforms or wearing uniforms pre-treated with permethrin, issuing of DEET, mosquito netting, getting rid of standing water. I mean, these were all part of our standard reporting instructions for Southcom because of other illnesses or infectious diseases such as dengue and chikungunya. So those personal protective measures applied to Zika. And of course, as you mentioned in a couple slides back, the new spin with Zika was the sexual transmission part of it and the incidents that we're seeing with birth defects. And what we needed to do is we needed to put out forest health protection guidance to the field on how our folks can protect themselves both during the deployed setting and also coming back post-deployment to the United States to keep the spread of Zika from occurring. And we put out that guidance through our reporting instructions that goes out to the services as they prepare their personnel for deployment to the Southcom area responsibility. We also worked closely with the Department of State because many of our forward deployed or forward stationed individuals are working in the embassies in Central America, South America, and the Caribbean, and they rely on the embassy medical units for their education. So we worked with the Department of State to provide education to our personnel that are stationed in the area downrange in order to be able to educate our personnel on Zika. We created a Zika website on the Southcom homepage that people can reference and get the most recent information for Zika. So that's kind of how we did the education part of the Zika prevention.
Yeah, thanks, Colonel Casuela. And I'll be asking you a little bit more about some of the other measures you took. As I mentioned, the blood supply was a big issue, particularly in Puerto Rico. Without an FDA licensed test in March of this year and with the growing number of cases there, local blood collection was actually suspended at the beginning of March. And blood supply actually had to be provided from the United States. It created a lot of pressure to create a test to be able to make the blood supply safe. And less than a month later, the FDA actually worked to grant an investigational new drug use to Roche for a product, and then subsequently has granted a number of emergency use authorizations for products that then allowed the testing and the ability to then give blood in Zika endemic areas. And I would just ask Dr. Ballou, can you kind of talk at a high level about emergency use authorizations?
Yeah, so the emergency use authorization is a mechanism that the FDA has that allows it to grant authorization for use of a previously unlicensed drug, diagnostic, vaccine, some medical intervention that would otherwise have to be licensed on the basis of a number of factors. It needs to be something which will address a serious disease. If there is any safety concern in its use, there needs to be some safety data already collected. There needs to be a reasonably compelling data set suggesting that the test will work or that the drug will be efficacious. And there has to be no alternative available. So those four criteria are what the FDA uses to consider a product eligible for an emergency use authorization. It is different from the traditional licensure pathway, which takes much longer and is more complex in that it satisfies some of the parts that the FDA needs to be reassured that the product is safe and effective, and then allows that the device or the drug to be used legally in that setting. It can be used for a previously licensed product for which there is no indication in the label, so that it would be off-label use, for example, that the EAU can be used in that context. But the key is that this has allowed, I think, almost a dozen diagnostics now to be made available in a relatively short period of time. And I think it does reflect that the FDA does have very efficient mechanisms that can be applied when it's necessary.
Thank you. Okay, I know right now there's no Zika vaccine. There is a lot of research effort being put to this vaccine. I know I read a couple days ago that Dr. Fauci from NIH certainly was looking to have potentially something available by 2018, although maybe not in a fully licensed form. And Dr. Ballou, I know this is your field of expertise in terms of vaccines. We have heard that it takes $1 billion and 15 years to actually get a vaccine license. What is your assessment here in terms of Zika? What are the hurdles, and can we kind of expedite that process?
Well, you're right. It takes a long time and a lot of money to develop a vaccine. There are specific hurdles around Zika, which, and partly it's the fact that we don't fully understand the disease and the pathogenesis, and the fact that there is this intriguing link between outcome with Zika and prior flavivirus infections. So that understanding that and being clear whether or not dengue, chikungunya, other flaviviruses, and Zika somehow would interact with each other in a vaccination approach, I think is a significant hurdle for vaccine developers, particularly since many of these will be applied in areas where there are ongoing dengue transmission. Right. So are there shortcuts? I mean, the good thing is we have an animal model, and it looks pretty predictive. Yeah. And that has certainly moved vaccines into the clinic. The clinical trials are ongoing, and they will be necessary to establish that we know what the dose is, we know what the schedule is, we have some sense of what the safety profile is. 2018 is a reasonable time frame in terms of when we might know that, but certainly for a licensed vaccine that would be available in any kind of scale, it's going to take quite a bit longer than that.
Thank you. You know, I think when we sat on the stage last year, or probably a couple years ago, none of us had an Ebola response plan. We all had a pandemic, maybe influenza after the H1N1 outbreak in 2009, and clearly none of us probably had a Zika response plan. George, Dr. Narby, I'd like to kind of have you walk us through a little bit about crisis management planning, which is a standard, and point out kind of the value of an enterprise, health plan.
Okay, thanks, Ken. I think the military and the DoD is certainly very familiar with contingency planning and the things that go into that. I think it's important to point out that contingency planning and business continuity is part of the corporate world as well. And certainly within that is crisis management, and within crisis management is the enterprise health plan, which addresses things like pandemics, emerging diseases, and even some things like nuclear and biological events. I think, the enterprise health plan is really to sort of create a way to impart safety upon employees, expats, travelers, and staff, and also assure continuity of service for what that business does. And certainly, in our case, with the TRICARE Overseas program, it was about continuing to provide care to beneficiaries should they be evacuated out of a Zika endemic area. we actually delivered a Zika contingency plan to the TRICARE Overseas office in early February that really outlined communication, roles and responsibilities, who's going to do what the responsibility is, and things like that. I think it's important, obviously, plans, as everyone in the Defense Department is well aware, plans are dynamic and iterative, and they need to be revisited and revised as we go along. One thing that International SOS does is we actually have a portal for our corporate clients that has a number of diseases so that companies can say, well, you know, what diseases do we have to deal with? What things do we have to face? There's a list. The portal is designed to be sort of layered so they can get deeper into specific issues if they so desire. There's standard communication packages, up-to-date references and things like that that we use. So I think that, you know, there's a lot of value in sort of having a general plan. Who's going to do what? Who's going to be on the team? How are we going to continue to do what we need to do in the face of a given crisis? Thanks.
Thank you. You know, one thing that's interesting, and I'll just point out a couple survey points. By March of this year, after the public health emergency, after the WHO had actually recommended deferring travel, Cardis is a relocation company, and they surveyed a broad variety of organizations to include the corporate world. And when you look at the response, in terms of policies and planning, as of March, less than half of these organizations actually had a formal policy in place to address the health crisis. And you look at, less than 6% where employees were being evacuated or considered for evacuation from the affected area. This is more than a month and a half after the DoD and Department of State actually made a statement, which Colonel Casuela will talk to later. Another measure in terms of duty of care and providing the necessary education and mitigation. The majority of companies in this OSAC survey essentially directed employees kind of for self-learning to either the WHO or the CDC website. It's telling again that less than 38% permitted female employees to defer travel or relocate from area where Zika was actually endemic, and less than 21% of males. You know, this was well into the actual epidemic. We've already talked, CDC did issue this travel health alert level 2 in terms of enhanced precautions. Remember, they issued a level 3 warning for Ebola in terms of a very strong advisory against travel. And I'll ask both Dr. Targino and Colonel Casuela to just tell us a little bit, how did you manage the men and women that were deployed to endemic countries, starting with Dr. Targino?
Sure, thank you. So there's two populations that we think about. One are our employees who permanently live in areas of endemic transmission. We have a large workforce in Brazil. And then employees who are traveling to those areas, and we had different focuses for both. For the employees who live in the area, it's not possible to take 5,000 employees and relocate them out of Brazil. In that case, we focused heavily on local vector control. We have a plant in São José dos Campos in the state of São Paulo, and they had work crews going through the plant, literally centimeter by centimeter, looking for standing water and other opportunities to have mosquito breeding eradicated. And we had very good success with the local grounds and maintaining those as mosquito-free as possible. We actually had no cases of Zika in the immediate area, and also the city itself of São José had very good local vector control. Yeah. So locally at the factory site, also in cooperation with the local cities, we try to make local transmission as low as possible, and also provided every educational material that we could in every opportunity. We put up posters everywhere. We tried to augment the local communications that were going out. For travelers, we did not feel that we could ban travel per se. We had to balance the autonomy of our employees and confidentiality issues. For example, if a woman were 6, 8 weeks pregnant and did not want to, how would we identify every pregnant woman? Would it be suddenly a travel ban on every woman of, childbearing age? So we thought the best balance between autonomy, confidentiality, and protection is to provide education and information aggressively and be very supportive if an employee, for whatever reason, did not feel comfortable traveling. And so we made it here's all the information, make the decision that's best for you in conjunction with your treating provider, and we will support you. And so those two approaches were our big arms of focus.
Dr. Cachuela.
Well, with regard to Southcom and the Department of Defense, force health protection is always a standard part of the deployment preparation process. It is the responsibility of the services to make sure that all the medical readiness requirements that are required for deployment are completed. So every combatant command provides force health protection guidance in its reporting instructions, and Southcom is no different. So we've always had, because of the issues with dengue, chikungunya, malaria, yellow fever, force health protection guidance for the Southcom AOR that talked about personal protection, vector avoidance. That was standard. And what we did is put in the reporting instructions specific requirements for Zika to include, the folks that go into the Southcom Air responsibility for temporary duty. If you are a female and you are pregnant, you did have the option now of voluntarily saying, no, I choose not to go into the Southcom Air responsibility, into a Zika-affected area, because I'm currently pregnant. So we provided that option. So that was sort of one of the different changes that we made to our force health protection requirements for deployment into the Southcom area of responsibility.
Right. Thank you. In terms of, we talked about the changing recommendations as it became apparent that Zika could be spread via sexual contact. And how did you manage people then coming back from these endemic areas, Dr. Targino and Colonel Cachuela?
So we, again, were very proactive in providing the information on the symptoms so that every employee can make sense. These are the potential symptoms of Zika. If you are experiencing any of these, you should see your treating provider. We also decided that if you were asymptomatic, but you had a personal concern, you had a spouse at home that you were concerned about, or otherwise felt that you wanted to get tested, we considered that a work-related exposure, and we paid for the testing ourselves. So again, we tried to be supportive of putting the choice on the employee and allowing them to make the choices that make them most comfortable and that they felt well supported. But there was really no blanket, we treat everyone the same way. We provided information to everybody the same way, and then they made their decisions that seemed to be the best for them.
Thank you.
Well, for DOD, a post-deployment health assessment is a standard part of the redeployment process, whereby when the member returns back to home station, he goes through different sections of his base to include the medical section. The challenge with Zika was, again, one, the sexual transmission part, which we had not seen with other vector-borne diseases in the past, and also the fact that 80% of those that were infected were asymptomatic. So what we had to issue out to the services in our reporting instructions for people returning back from deployment is if you should show signs of infection with Zika, to go ahead and report to your primary care provider and let them know that you have been deployed to a Zika-affected area. We also put into the post-deployment guidance the precautions for either abstinence or protected sex initially for men, and then subsequently, as the evidence came out, for women. Yeah. So those are some of the unique requirements that we put into our post-deployment requirements for Southcom.
Thank you. I don't want to leave you out, Dr. Norby, so I want you to potentially comment on, I know International SOS advised quite a few beneficiaries who were living in endemic regions, so can you give us some insight on that?
Well, I think Dr. Targino and Dr. Casuela really hit upon something important. Patients need to be informed because, as we said, it's the patient, it's the beneficiaries, it's the soldiers, the active duty members and their family members that have to make the decision for themselves. So what's critical is that those people have the same set of information, that informed consent is uniform across the board. And one of the challenges we had was, well, what pile of information, where is this information going to come from so that we can be assured that within the Department of State, within the DoD, within International SOS, with the TRICARE Overseas program, everybody's getting the same information from various sources. So very early on, from DHA, the directive was to use the CDC information as that source of information. And just for everybody's awareness, the CDC came out with a great key messages document on Zika on the 22nd of November that was really nicely summarized all of the things that we use, so that I'm telling the people the same things that Dr. Casuela is, that Dr. Targino is, for that. And it's obvious, it's prevention, preventive transmission of vectors and sexually, and then pregnancy avoidance. And if you are pregnant and in an endemic area, what should you do then? And I'll save that piece because we're going to touch upon that in a moment.
Okay, now, Colonel Casuela, it appeared as both Department of State and Department of Defense stepped out as early as late January in making the decision to allow pregnant women to voluntarily evacuate areas where Zika was endemic. You saw the corporate world, you're talking about March, still, maybe not making that same choice. So can you kind of give us a little bit of a background as to how that happened? And, were you out on a limb? Did you get support on that?
Yeah, thanks, Ken. It's a great question. As we were watching the Zika outbreak in Brazil, most of the focus in the U.S. is what will we need to do if Zika made its way into the United States. For us in Southcom, like many of the corporate world that had people working in affected areas, we were living it. Every day we had people deploying in and out of Zika-affected areas. We had personnel in our security cooperation organizations at the embassies with their families living in Zika-affected areas. And, every combatant command surgeon's #1 priority is to provide force health protection guidance to make sure that we maintain the strength of the force. So at Southcom, we felt like we needed to be proactive and provide recommendations to the combatant commander on what we needed to do in order to minimize the risk of Zika to both our folks that are deploying in and out of the Southcom area of responsibility, and for those members that are actually stationed in Zika-affected areas with their family. So the great thing about Ebola was we developed a process. We had developed working groups to talk about what we needed to do for Ebola. So we convened that same group at Southcom, a Zika working group that had representatives from all the directorates to include our interagency directorate. So not only was DoD there, but we had Department of State, Health and Human Services, USAID present in that working group. We also worked very closely with the Western Hemisphere Department of State medical officer, who happens to be headquartered out of Fort Lauderdale, just up the road from our headquarters, knowing that they were dealing with the same issue, because those Department of State personnel and those DoD personnel working in the embassies are literally working, side by side with each other, and we knew that we needed to walk, step by step with the Department of State on this. And then we also convened a larger community of interest that we had formed with Ebola, with both the interagency here in Washington, D.C., again, primarily, USAID, Department of State, Health and Human Services, but also with the Pan American Health Organization. So based on the discussions in the working group and getting what we were, receiving data-wise from the CDC, from Armed Forces Health Surveillance, and also we took a trip into Brazil and we're talking with those providers and those epidemiologists that were fighting the Zika battle at ground zero. We came up with our medical recommendations for the combatant commander. And again, our biggest concern was with pregnant females and preventing, the birth of babies with birth defects. And so what we really felt obligated to do was protect that group and at the same time acknowledge the autonomy of the patient. So what we did is we proposed to the combatant commander that we need to institute a policy whereby if you had a pregnant female that was either active duty or a dependent working and living in a Zika-affected area, that they should have the option to voluntarily come back to the U.S. and be moved out of the Zika-affected area. And again, looking to maximize protection to the force, but acknowledging the autonomy of the patient to make that choice. And again, we were working that hand in hand with the Department of State, and that was a similar policy that they were putting out. And again, working with the Department of State, we were working with the medical health units to make sure that they were providing the medical information to both the Department of State and the Department of Defense members at the embassies to make sure that everyone was getting uniform information in order to make an informed decision on what to do with regard to voluntary relocation for pregnant women.
Great, thank you. Okay, I think I'm going to probably skip ahead a couple of things just in the interest of time because I do want to allow time for questions, and I know we're getting near the end of the hour. One thing I do want to quickly ask Dr. Blue and Dr. Targino is whether you think the private sector can ever influence this public funding, using Zika as an example.
Well, I think for us, we tried to provide consistent information that was in cooperation with what the CDC putting out, not just internally to ourselves, but also to the public. And as an example, we had a video on YouTube that you could access on Johnson & Johnson's response to Zika. For my specific group within J&J, we don't actively lobby the government per se, but the more consistent we can get out a message, and both internally and externally, I think that supports the groundswell of opinion that then I think will influence back. So in a roundabout way, by providing consistent information, we can be supportive of that.
Yeah, GSK, and I think it's true of other pharmaceutical organizations, doesn't directly lobby government for funding, but we do have a part of our organization that has very close ties with the legislatures, that provides information, that responds for requests for information, and lets policymakers be aware of what industry is doing, how it's approaching things, and when industry has ideas about how things could be potentially made better, to provide that information and those suggestions to government. But and I think it's a dialogue.
Good, thank you. Okay, I'm gonna skip ahead. I had another hour of questions, but I think we're probably going to be out of time. So all these slides are in your packet. We're going to talk about the Olympics, about Zika funding in general as compared to Ebola funding and the speed at which it took place. a little bit about vaccines, which I know Dr. Ballou has already touched on, but I would like to get to a potential solution in a way that whole of government, academia, and private sector can potentially work together in a more cooperative, comprehensive way. As part of the national security strategy in 2015, the president laid out that he wanted to develop a capacity to respond to these type of threats in the future, and he put a lot of emphasis on the global health security agenda. It has gotten quite a lot of attention and discussion, I think, in this forum yesterday, and I'd just like Colonel Cashuela first to comment on that and how it's affected the way that you're managing Southcom. And then Dr. Targino, I know Johnson & Johnson has been one of the leaders actually in the private sector roundtable with the global health security agenda and how that has really brought those communities together.
Sure.
Yeah, thanks, Ken. You know, it's always been acknowledged by the combatant commands that, you know, one of the components to overall security for a region is health security. And as we saw with Ebola in West Africa and as we saw with Zika in the Western Hemisphere, that infectious diseases can be a potential threat to overall stability and security. And so we have been completely supportive as an overall U.S. government interagency approach to the global health security agenda. And our focus in Southcom in particular, working with the interagency, has been trying to build capabilities and capacities within our partner nations to prevent, early detect, or mitigate infectious disease. And so we've been working closely with Department of State, USAID, you know, Health and Human Services, in order to build those capabilities in our partner nations. So that's how we approach the global health security agenda in the Southcom area of responsibility.
Thank you. And for Johnson & Johnson, we have built into our identity as a company a document called the Credo, and it goes in order of importance of who we focus, who we serve. And as you know, our customers, the family of our customers, our communities, our employees, our shareholders at the very bottom. And so it is built into everything that we do that we acknowledge responsibility to the communities of the folks who use our products. We have a responsibility to them. And whether that manifests itself as good local communication, as I mentioned the example of vector control in the local communities, but also we have a group within Johnson & Johnson that works with communities at risk of various global pandemics and risks to whether it's help with vaccine deployment or other public health strategies to decrease local diseases. So both from a very granular local level, but also from a organized, centralized approach to communities that have special needs, we really feel that it's part of our mission to make the communities where we have a footprint a healthier place. And so it's not considered something extra or something nice to do. It's really built into our identity that this is important for us to help the communities.
So it does sound like, you know, since its kickoff in 2014, that the GHSA, you know, both from bringing the military and the whole of government, HHS, DOS, CDC, others together, and then actually tying in the public sector, which was a goal that we kind of mentioned at the beginning of this, that has somewhat been effective?
Well, from a Southcom perspective, it's more than just a whole of government approach.
Yeah.
It's a whole of society approach.
Yes.
Because one of the key partners that we have in the Southcom area responsibility to help us, you know, work towards the global health security agenda is the Pan American Health Organization.
Right.
And we work very closely with them and the signature nations in the Southcom AOR to the global health security agenda to, again, build that partner nation capability and capacity to prevent, detect, you know, respond rapidly and mitigate infectious disease, and also to help them comply with the international health regulations and the reporting requirements as set by the international health regulations by the UN in order to achieve the objectives of the global health security agenda.
Thank you. Okay, the references and resources will all be in the slide deck that you get, but I want to open up the audience for questions, and I think there's a mic up here, and there may be one.
Actually, there's always a bad guy to the group, so we've got one question. Make it good.
We'll be outside.
And I would invite the panel, if you have time, to be in the exhibit hall at any time to be available there. But one question.
Well, I hope it's good. I'm Jack Taylor from BITS, but I'm a general surgeon, not an epidemiologist. The question I have is there a methodology that is being engaged by you and the Pan American Health Organization and others to accelerate vaccine production as against the usual 17 years of the VA? Because this is a complex situation where you have asymptomatic patients, you've got multiple disease transitions and non-apparent, and we've been using mosquito nets for about 150 years. So that there's going to be a demand for the vaccines that's going to exceed the expectations or the delivery schedule of the FDA, in my opinion.
Well, like you, sir, I'm not an epidemiologist or an infectious disease specialist, but I did stay at a Holiday Inn Express. But I am a surgeon. I'm actually a surgeon who is a command surgeon who is a surgeon. But from a DoD perspective, we have worked closely with academia, with our research centers, particularly here in DC, to try to accelerate the production and approval of vaccines for use in the force. So we saw that with Ebola. We're seeing that with Zika right now. So that's probably a very good illustration of where public and private are coming together in order to accelerate the process.
I think the mechanism that the FDA has, the emergency use authorization, will certainly speed up the process. But the reality is that even if we had a vaccine that we knew today could protect an individual against Zika infection, and we may have that data by 2018, there is just a built-in time frame to ramp up, to scale up, to manufacture, to release vaccines that all the legislation in the world is not going to change. There is a process there, and it is going to take longer than we would like. But I am sure that everybody who is working on this is doing everything they can to bring these products to the field as quickly as possible.
Okay, great. And with that, I'd like to thank the panel and Dr. McDonald for a great presentation. I think we could have gone for about another hour,
yes.
I would imagine. And we want to thank all you, the early birds that came out and were able to get a cup of coffee and listen to a great presentation. Thank you very much, gentlemen.
Thank you.